Hello and welcome everybody to this webinar on Shockwave for the elite athletes. Thank you very much for joining us this evening. Just a brief format of the webinar. We're going to do a 20-minute presentation and then we're going to have an interactive Q&A session. Just a little bit of housekeeping. The session is being recorded, which you'll get access to in the next couple of days. But because it's being recorded, if you haven't muted yourself already, could you please do so just to make sure there's no background noise. If you do have a video, please feel free to share. It'd be great to see who's on here. And if you do have any questions, you have the chat box at the bottom of your Zoom screen. So if you pop your question in there, and when it comes to Q&A, we'll get them answered for you. So just a quick introduction. My name's Dominic Smith. I'm the clinical application specialist at PhysiQuip. And at PhysiQuip, we aim to bring some of the most innovative MSK applications to the UK and equipment to the UK. Now, we were introduced to Focus Shockwave a few years back from colleagues in the States and Australia, and it's been a really exciting area of development for us. And from this area, we started working into diagnostic ultrasound as well, which we really felt the need to offer the best practice solution for Shockwave. So with that said, I want to introduce Dr. Anders Brogard. This evening, he is joining us from Denmark and will be leading the session. Now, Anders has over 20 years of clinical experience using Shockwave. So if you do have any questions, particularly around clinical application, also the mechanisms are working, then it's a really good chance to pick the brains of one of the best people that uses Shockwave. So with that being said, Anders, I will hand over to you.
Thank you, Dominic, and thank you, PhysiQuip, for inviting me to this short little webinar. We don't have very much time, but hopefully you'll be able to get some hints about how we can use focused shockwaves and how they work in the elite athlete. Just to start a little bit about myself, I'm a chiropractor and I work in Copenhagen in a private practice, and it's a multidisciplinary clinic where we see spinal and sports injuries. So we utilize radiological devices like MRI scans, ultrasound and X-ray to diagnose our patients, and we work very close together with our physiotherapy staff, sports physicians and orthopedic surgeons to manage these elite athletes that we see. About 20 years ago, I was heavily into sports medicine and was affiliated with several football or soccer clubs and handball clubs here in Copenhagen, Denmark. And I saw an increasing number of elite athletes, which I had to manage with the rest of the medical staff. And I was introduced to focused shockwaves and has since then tried to utilize that modality in treating and managing our patients and perfecting it as much as we can here in our clinic right now. So you are gonna hear a little bit about the science behind the focused shockwaves and the clinical applications that I can actually share with you today here. So what is a shockwave? Shockwave's mechanism of action is actually based on acoustic mechanical waves that act at a molecular, cellular and tissue level to generate a biological response. And when we look at definitions, then a shockwave is a sonic pulse that has some physical characteristics. It has a high peak pressure, more than 100 megapascal, and a very fast initial rise in pressure during a very short period of time, 10 nanoseconds, and which is followed by a low tensile negative phase. It has a very short life cycle of approximately 10 microseconds, and this is what we actually use when we use these focused shockwaves machines. A little bit about a graphical like illustration. So you see the initial fast rise phase with a very high pressure followed by a tensile phase, and both of these wave characteristics are actually producing some biological results in human tissues. Just to compare with some other technologies, we have a comparative graph here, which shows the shockwave in red and a diagnostic ultrasound wave in the blue graph. And as you probably radial pressure waves, which are also utilized in sports medicine. Today, I'm just going to talk about shock waves, real shock waves, because radial pressure waves are sometimes also called shock waves, but they are not true shock waves because of their, as you can see of this graph here, they have a rise time and a pressure pulse which is longer, and the total pressure output is not as much lower than focused shock waves. The modes of action of these two therapy modalities, focused shock waves and radial pressure waves, also differ, since in a little while I'm going to go through the biological effects that focused shock waves have, and they have only been shown in the literature by using this technology. So these two technologies, they differ in their generation devices, their physical characteristics, and the mechanisms of action in human tissues. Just going a little bit further, we have three different ways of actually producing these focused shock waves, and I'm not going to dwell too much on that, but we have a way of doing it by an electrohydraulic principle, where we have a spark plug where through you produce a plasma bubble by high voltage discharge, and it is then focused in this focused shock wave, which you can see on top of the device. We also have another technology called the electromagnetic, where we have a high voltage discharge over a cylindrical coil or flat coil, which again can actually focus a shock wave. And then further to the left, you see the piezoelectric technology, where we have lots of ceramic crystals where high voltage is actually let through to, and they generate and expand and produce a focused shock wave to it. They all differ a little bit in how you apply them in practice, but I have now, I think, worked with all three technologies, and I think I work with all the different manufacturers on the market right now. And we still utilize several of these different technologies in our clinic today. So how did the shock waves come around? In the early 80s, shockwave therapies was originally developed to disintegrate urinary stones called lithotripsy. And here the patient avoided open surgery to actually disintegrate these stones here. When this technology was applied at hospitals, surgeons actually saw that when they actually targeted these urinary stones up through the pelvis, they saw that the reflected shock wave, which actually hit or targeted or was displaced to the pelvic brim, they saw a buildup of cortical bone there. And then some surgeons tried out to actually use this technology on other chronic conditions which did not always respond to conservative treatment. So some few German doctors at a hospital setting started treating bone disorders, especially delayed or non-union fractures, and later on stress fractures. And in 1991, Radial and Mikhailov, they did a study, and they actually saw very good results of treating these non-unions with focused shock waves. Just 1 or 2 treatments had a very large success rate. Here we have an example of a fracture gone wrong, where the external fixator did not actually succeed in treating these bones, but applying 1 or 2 treatments of focused shock waves after 3 to 8 to 12 months, we saw a complete resolution of these fractures here in about 80 to 85% of the treated patients. And that led on a lot of research on animal studies and also on other human tissue studies. Shortly following this study, we saw a lot of other studies actually which actually target bony lesions. Here's another picture of, let's see, a hip fracture, where you can see how well it healed up after one treatment here. Taki did a study on stress fractures, where he saw the same results after 6 to 12 months. He saw total resolution with a success rate of about 85%, 82%, I think it was, on a quite large population here. And it was all without any side effects or complications. Since then, there's been done a lot of studies on other tissues in the body, especially collagen tissue, fibrous and hyaline cartilage, muscular tissues, and these biological responses also seem to be adapted by avascular tissue. Here's another study just recently published by some Japanese scientists, and they actually tried to treat a meniscal tear in the avascular region of the anterior horn, and just for one treatment, after I think it was 8 weeks, as you can see at the upper level and lower level, we see at the upper level the control group which did not receive Shockwave, and like the Shockwave group underneath. After 8 weeks, we saw total healing of the anterior horn, even though it's an avascular tissue. So a lot of biological responses actually occur when we use focused shockwaves on living tissue. And it's not only applicable to vascular tissue, but also to avascular tissue. And that creates a large sphere of possibilities to what we actually can treat in these elite athletes and which structures we can target. Most of the double-blind and randomized control studies of very good qualities are done on tendon disorders and chronic tendinopathies. And we have quite good moderate to low evidence that it is very effective, especially followed with a rehabilitation regime. It seems to be quite effective to treat these disorders which don't respond to conservative treatment. There's some disagreement about dose and treatment parameters and protocols because they haven't been properly described in the literature. So as a clinician, you have to talk with a lot of other colleagues who use these devices and try to make your best regime for each and individual condition that you actually see in your daily practice. In tendinopathies, we see different kind of stages and different tendons that seem to behave a little bit different. We see acute conditions, we see conditions with a lot of vascular ingrowth, neurovascular ingrowth, and we see some chronic conditions with calcifications and partial ruptures. To the left, you will see a comparison of an Achilles tendon, which you see up here, a healthy one going down to the calcaneus, and an unhealthy one, a thickened tendon, hypoechoic, with thickening of the peritendon, and you see changes here in the Kager's fat pad. It's a very common picture. To the right, you see with the Doppler activity on, and we see a lot of neurovascular ingrowth, which comes from down here from Kager's fat pad. We see that very often in Achilles tendinopathy and patellar tendinopathy, and they seem to be quite resistant to conservative treatment. Here we find great use of using the focused shock waves, because several studies have actually shown that these ingrowth that you see from the fat pads going into the produce pain and structural weakness. We actually see a decrease in numbers and size of these C nerve fibers, which actually go in and produce increased pain in these tissues here again. So this has been established by several studies now. And we can also see that during the treatment, after 1 to 3 months, we can actually see on the ultrasound scans that these fibers retract and that the neurovascular ingrowth actually diminishes. Here's another slide histologically where you can see these C nerve fibers actually decreasing in size and retracting. Studies have also been done on calcific tendinopathies, especially in the shoulder, where we see very good results. Rumpe et al. Did several studies here in the 90s and early 2000s, where he showed very good results by targeting these calcific deposits in the tendons and thereby avoiding needling and surgery for them. So this is an indication that we see very often too, not only in the shoulder tendons, but also in the Achilles tendon and other muscular structures where we can use the focused shock waves in the same way by utilizing diagnostic ultrasound or X-ray to actually localize these areas and treat them with great success where conservative treatment has failed beforehand. So these effects have scientifically been investigated and shown to be partially true, that shock waves actually increase cell permeability by depolarization of the cell membrane. We see a stimulation of microcirculation. We see a modulation of many biological substances. Here, substance P, which is a pain modulator, and we see involved in a lot of tendon pain and ligament pain. As I showed you before, we see reduction of non-myelinated nerve fibers in these tissues after shockwave therapy. We also see angiogenesis and vascular ingrowth by release of nitric oxide and vasodilation. You can actually see that straight after treatment that you have some effect there when you ultrasound scan them. It also has an antibacterial effect, but it also has an effect on release and stimulating of growth factors. And that has been shown in nearly all human tissues: cartilage, synovium, epithelium, bones, and collagen tissue. We also see stimulation of stem cells, which seems to be very, very powerful. And then we have this stimulation of neuron and pain modulation. And that is not only shown at the periphery where the lesion is, but we also see at spinal levels. After a few treatments, you can see modulation and reduction in neurons and size and the neurotransmitter modulation at that stage too. And some new studies have also shown some involvement of higher cortical centers. And as you know, that pain physiology is quite complex. So we haven't found out exactly how that works yet. But when we use focused shock waves, we don't recommend that you anesthetize the patient. Lots of studies have actually shown that if you do not anesthetize them, you get much faster pain relief. So sometimes you see a reduction in pain of 50 to 80% after 2 or 3 treatments. And we know that tissue regeneration hasn't occurred yet. So there is some central stimulation of the pain pathways by using these focused shock waves that we don't really understand yet. but in clinical practice, it seems to work. So the main messages that I just want to give to you is that shockwaves actually can modulate pain, and due to complex spinal and local pain pathways, but it also can incur tissue repair and speed up tissue regeneration. And that seems to be universal to all these muscular tendinous structures that we see affected in the athlete. And 20 years ago, when I started actually working a lot with these elite athletes, it was imperative that we were able to speed up the recovery time and speed up how fast the patient, the elite athlete could go back to the pitch again. And by using focus shock waves in conjunction with our other therapies, we have found that that is actually possible. And it's also possible to treat other conditions that you would not normally be able to treat conservatively, but where you would have to rely on injectional therapy or maybe referral for an orthopedic surgeon to see if something could be done about the lesions. Focus shock waves are non-invasive. They have nearly no side effects, none really mentioned in the literature, or I haven't seen any in my clinical practice. They can speed up tissue recovery, both acute and chronic conditions. I know that the literature has shown that it's mainly chronic conditions that has shown evidence, but the more you use it in a clinical practice, you can actually modulate pain and speed up tissue recovery for many conditions in these athletes which are very keen to go back to sport again. They can also happen immediately in most cases, especially in the acute conditions. They can desensitize painful regions and improve proprioception and actually cause that we can load them faster and accelerate their regimes in exercise. We also have the possibility with these focus shock waves not only to treat superficial structures, but also deep structures inside the body, interarticular structures, which we cannot get to in any other way but by doing injectional therapy or invasive surgery. So focus shock waves are very, as the name implies, they are focused, so you can actually target different structures and you can use it as a diagnostic tool to actually reproduce the patient's pain to make sure you are at the right area for treatment. We use it for a lot of stress fractures in the clinic, 1 or 2 treatments with immobilization up till 4 to 6 weeks with great success. We also use it on early cartilage lesions around the knee and ankle especially, sometimes also in the wrist. The use for tendinopathies has been well established, and we use that on a daily basis. And due to the anatomical likeness with ligaments, we see the same result with ligament lesions and ruptures with also partial ruptures and smaller avulsions. Degenerative changes seem also to respond well if they are, we deem it a candidate for treatment. And also acute inflammatory and chronic changes can actually be seen with using the focus shock wave. It seems like by using focus shock waves that over the years that the more vascularized the structures are, the faster they respond. So muscle strains and partial ruptures seem to respond very, very well, and we can increase recovery time for these injuries when we use focus shock waves. We also see, especially in the lower extremity, impingement lesions due to synovial hypertrophy or scar tissue around the capsules, where we can use the focus shock with great effect. And lately we've been using the focus shock waves. Complementary therapy like PRP injections, where we have found not very good results with immobilized structural injuries, where you have to immobilize them. Studies have shown that you can actually, straight after an injection with PRP and by giving them focus shock waves, you can activate and stimulate these stem cells to actually start a regeneration of the structures which have been injured. Also, we use the focus shock waves after specific surgery, like ACL surgery, where we sometimes see loosening of the ACL at the tibial plateau due to the screw does not get the right bony healing. By just giving one treatment there, we can actually avoid the tibial plateau syndrome, which actually happens with about a few % of those patients which get operated. So there's quite a lot of possibilities because of this regenerative effect of the focus shock waves in both acute, chronic, and other conditions which have received surgery. So key messages. I know I've been running through this here very fast. Focus shock waves have the ability to treat all musculoskeletal tissue injuries, and both for pain reduction and tissue regeneration. We also use it preventative with small overload lesions, where we treat them before they go into any injury state. And early stages of injuries, you can actually accelerate healing time for. And because of focus shock waves actually elicit a very specific pain response, you can use it as a diagnostic tool together with comprehensive physical exam and radiological examination to accelerate performance and get the elite athlete back to play as fast as possible. This has been quite a go through the focus shock waves. So we have a little Q&A here. So I think, Dominic, are you going to lead it for us?
Yes. No, thank you very much for that, Anders. Very good information shared there, very detailed. So if anybody has got any questions, then you can put it through in the chat box at the bottom of your screen. But I mean, I've got a couple of questions to fire off anyway that might be of interest for some people. So one of the areas was fractures and some of the bony disorders. And with stress fractures, I've done quite a bit of reading in that area, and some of the studies are pretty good, some of them are quite weak. And I mean, in terms of your experience on treating those, I mean, how often are you treating them, and what are you trying to achieve when you're doing that treatment, and what, basically what's happening to the bone?
Yeah, we diagnose them, of course, with radiologically, and if you want to treat bony lesions, you have to be very specific. So you have to be able to use high resolution ultrasound to target the focus shock wave at the fracture site. You have to deliver the right dose with the high enough energy, and we treat those lesions once a week for 2 weeks, as say 2 treatments. And we see a callus formation within 3 to 4 days, massive callus formation. And I think our internal success rate is about 93%. They have to be immobilized if we talk about the metatarsals or the calcaneus with a boot for 4 to 6 weeks. So it's very few we have to send on to surgery.
Great. So we just had a question coming from Jose about what are the parameters that you would modify or change to treat healthy muscle for recovery after a high intensity activity or a game?
I would first, it wouldn't be the first choice of modality, I think. I would more go into physiotherapy modalities like massage and maybe a radial pressure therapy. I mainly use the focus shock waves more to prone certain injuries which the elite athlete is prone to, I've had before. or if there's indication of small overload of ligaments and muscle sprains. So there has to be some form of indication of tissue, minor tissue injury before I would use it actually.
Right, okay, so you not necessarily wouldn't be using it for healthy, you'd only be looking at injured tissues.
I think it's, as a clinician, I have to choose my my management the right way. So I would only use focused shockwaves if I suspect of some kind of tissue injury.
Mm-hmm. All right, great. I mean, one of the questions I'm gonna ask the question that we get all the time, and I think you know what's coming, is we always get the question of how does it compare to radial pressure waves. You've already described that they are two different things. Would you, rather than looking at clinical outcomes, would you change the question to what are the different physiological responses of the two?
Well, the thing is that I haven't seen at all any studies on the biological effects of radial shockwaves done in any animal study. So we have to think that these technologies, they are totally different technologies, and they differ in the generation devices, the physical parameters, but also in the mechanism of action. But they share the same conditions, and you can use them, may use them in combination for many treatments. I would primarily recommend to use radial devices, and I prefer them for more superficial and larger areas. Whereas if I have an injury to a musculoskeletal anatomical site, then I can actually generate and focus a larger amount of energy by using the focused shockwaves to get a faster response. So the deeper structures or interarticular structures in the body, I would also always use the focused shockwaves.
Cool. We've got a question from Emma Deakin. Emma, if it's all right, I'm just going to unmute you and you can ask Anders the question yourself.
Well, you can do, but I have got a little in the background.
All right, do you want me to ask it?
Yeah, you ask it. That's probably better.
Okay, no worries. So Emma's asked Anders do you use it proactively for chronic tendons after a period of relative offload and when they're going back into load, i.e. pre-season?
Yes, we do that actually. So if we have a suspicion or if we have a history of tendon overload or recurrence of injury, we actually can combine that when they start up the season with focused shockwaves. Actually to help regenerate the tissues and pain modulate them.
Okay. Hope that answers your question, Emma. Johnny, to try with yourself, you can ask the question directly to Anders. Should be able to hear you now, Johnny.
Yeah, hi there. Yeah, hi Anders, thanks for that. I was just wondering if, so I've had an athlete who I've been trying to desensitize his tendon during a season, and he's getting a 24-hour reaction to the treatment, so his pain getting worse in his tendinopathy. So would you continue with this treatment, expecting kind of a long-term resolution in his symptoms, as you spoke about using the mechanism you described earlier, or would you stop using the shockwave as a treatment?
I'd say we rarely see an increase in pain after shockwave, focused shockwaves. You actually normally always see a pain reduction just after the treatment and 24 hours afterwards. And the doses that we use, energy levels that we use, cannot cause any harm to the tissues. So I always use energy doses that can only cause regeneration. So a few patients have an experience of increased pain over a few weeks, but I don't find that clinically relevant for stop treating them. Does that answer your questions?
Yes, thank you.
Okay.
Perfect. Thanks, Johnny. I mean, just on the going back to the bone aspect, I find it's quite interesting about the applications with bone. And also you mentioned about the sort of the meniscus tissue. I mean, how often have you used it on articular surfaces, bone, and that aspect, those aspects? And what are you stimulating?
Yeah, what are we stimulating? We know it has the ability to actually stimulate collagen, both and fibers and hyaline cartilage and bone tissue itself. But also we have to put into a clinical context and structural diseases actually cause pain. We see a lot of meniscal wear and tear, which is not really relevant for the patient's pain. So you have to look at the lesion sites when you examine the patient. You have it can be very helpful if you have a high resolution ultrasound device you can use, because you can see small alterations in those parts of the tissues which are actually innervated by nerves. And it's only peripheral parts of the meniscus and the attachment sites which are actually innervated and causing pain often. Otherwise, if we have large meniscal tears and loose bodies and other structural things that cause needs surgical examination and maybe treatment, we find by treating these early stages of irritation and injuries to the periphery of the meniscal lesion, especially the medial part of the meniscus at the attachment site, small coronary ligaments, which are the deep parts of the medial collateral ligament, we see them often being painful by palpation and by loading and by twisting and examination. And they respond very well and very fast to focused shock waves. So you have to have a broad clinical, be pragmatic when you actually treat these patients. It's not always that anatomical deficit will actually give you the reason for their pain. And then again, that's where I find that focused shock waves actually very beneficial as a diagnostic tool, because you can target these structures within a few millimeters, and you can actually ask the patient if that reproduces their known pain. And that's a very helpful tool when you want to treat these patients.
I mean, on that targeting aspect, you know, when we've been working with other clinicians, we mentioned at the very beginning, is that we've got involved with diagnostic ultrasound because that's sort of considered best practice for using focused. A lot of these sports institutions that the delegates that are on now will likely have access to diagnostic ultrasound. Would you recommend doing a scan beforehand, pretty much, well, obviously to diagnose, but then to locate the exact depth that you're going to be treating?
Well, because I have the ability to use it, I use it every time when I diagnose my patients. I'd like to see the integrity of the anatomical structures that I'm going to treat. I also like to see the surrounding structures around the joint. It's not always a tendon or meniscus. You also have to look at the synovium and the ligament structures, and if there's any swelling surrounding these structures here again, because all these parameters can actually be part of the patient's pain aspect and functional deficit. And with focused shock waves, you have the ability not only to treat one tissue, but several tissues at the same time, which are clinically relevant in this condition that the athlete actually presents with.
Right. I think with, I just want to go back as well, when we're looking at tendinopathies and calcifying tendinopathies, it kind of seems a bit contradictory how the focused shockwave can stimulate bone healing, bone growth, and yet it can disintegrate the calcifications in the tendinopathy. So how do you explain that?
Well, I think if you, I followed many of my orthopedic surgeon colleagues, and they've been treating these like calcification in tendons and joints, and they have varying degree of density. And you have to take that into consideration. The more dense these calcifications are, if we're talking about osteophytes, I don't think that the focused shock waves have any indication or helpfulness in that indication. But most calcification in ligaments and tendons are actually more soft calcifications. And I don't think you disintegrate them, but I think you just stimulate the tendon around it to replace the soft calcification with tendon tissue or ligament tissue. That's my clinical evaluation of that and my thoughts about that actually. So I think you're just causing a regenerative effect, which actually causes a new modulation of the tissue. So you actually replace the softer calcifications with healthy tissue.
Cool. And with, because obviously a lot of the sports people dealing as well with muscle injuries, so hamstrings, quads, groins. I mean, when can you start to use focused shockwave? Because predominantly people, it tends to be using the chronic tendinopathy. But can you use it acute, subacute, chronic? When is a good time to apply it, particularly for muscle?
We've seen the best results by applying it straight away, immediately, because the more vascularized the tissues are, we found the faster the response. Muscle lesions or strains or partial ruptures in the rectus femoris or hamstrings or calf muscles, they respond very fast, and we can pain modulate them very, very fast. Within a few treatments, we can actually we can create an increased healing time here. We also see a very, very fast response in very chronic conditions like impingements around the ankle, where we see synovial proliferation and fluid buildup. We see it around the patella, plica syndrome, and synovial thickening, and prepatellar lesions too. We see a very, very fast response in those tissues which are very heavily innervated by vascular innervated.
And I mean, is there any particular sort of indication or contraindication depending on the grade of the injury?
No. With the doses that we use, and because it doesn't create any excessive strain or shear force on the tissues like massage therapy could do, or loading therapies could do, or even radial pressure therapy could do, we don't see any contraindication by using that. You just have to manage your patient properly, because sometimes you are very lucky to get them out of a lot of pain very fast, so they have to be managed properly.
Right. And I've just picked up Duncan's, he's messaged us with a question. So he has access to a good experienced physio who uses radial shockwave. What would you recommend as a sensible, safe, effective training plan from ground zero shockwave clinicians who might have other good experience treating with other modalities such as injection therapy, and his comments on the issue of training and competency, radial or otherwise?
So can I have that again?
So I think boiling down, it's like, what is a good safe way to train and learn how to use this? If I'm right with that, Duncan.
I think if you have some experience with radial pressure waves, you have a big advantage, because you're used to working with tissue compliance by using that modality. And you should actually be able to, with a short introductory course, go straight into actually apply the focused shockwave to the same tissues. And especially you'll be able to, as a clinician, just by scanning with the focused shockwave around the tissues, you'll be able to find the different pain responses that the patient complains of. And you can actually make a much more detailed plan of what tissues you have to treat, and which others are actually reacting to those tissues. So I don't think it, because it's non-invasive and it's a safe technology, I don't think you need that much to be scared about here. You just need to start using it in daily practice.
Perfect. Duncan's just messaged say that's answered his question there. Mm-hmm. So I mean, are there any other kind of injuries that, in the sporting world that you've come across, other to your typical tendinopathies that you've used focused shockwave for?
Well, we use it quite a lot for, like, say, ligament damages around the ankle, both acute and chronic, and these impingement areas. We also see it with the more deeper lying, compartment-like syndromes, like the pronator impingement and in forearm. We can use it for the deep structures down there where we have some nervous impingement. It seems to respond quite well to that too. It's very tender areas to go into. And injectional therapy is not always indicated by going into these muscular tissues. We see it very helpful around the hip, where we can target deep lying structures. We can actually go into the anterior part of the hip joint and pain modulate these patients too. iliopsoas tendinopathies we can target quite easily and quite safely. Also, lesions from throwers at the capsular and ligamentous complex in the shoulder, we can actually go in and treat and pain modulate and cause some regeneration in these areas too. So actually in all areas which are very tender to palpation or other therapy, it's a very good modality to use.
Great. So I think one of the other questions as well is one of the new sort of latest advancements of Shockwave. So you mentioned about the focus pinpoint. We know there's a linear source as well. So for those who've maybe not come across that before, can you explain sort of what the linear Shockwave therapy?
Yes. As I explained to you beforehand, we had the electrohydraulic and electromagnetic and the piezoelectric-like technologies out there. The electrohydraulic was the first one to be actually invented. They seem to produce a large spherical or cigar-like shaped therapy zone, which is not as homogeneous as dense and as dense as the other two devices. The electromagnetic lies just in between. It makes a cigar-shaped focal zone too, which can be displayed deep into the body. And then we have the piezoelectric, which have several modalities where you can actually choose the same shape of the focal zone, like cigar shape as the other two technologies. But you also have a new linear device, which actually produces linear shockwave, and it has a very large area you can actually treat at the same time. And as you probably know, many structures in the body are linear, ligaments, tendons, and you can actually treat them just by placing the probe on one place or two places and treat a whole clinical entity in a very, very short time, because you have a much larger focal zone to treat with. It doesn't penetrate as deep, but it goes down into 3 centimeters, so you can easily treat 90% of all the common lesions that you find in athletes by using that device. So you have many opportunities, and I always recommend people who go into focus shockwaves that they try out the different manufacturers' machines and see how they work. Some start up very slowly, some start up very fast, some can deliver more shockwaves per second than others can, and the power output is also different from each machine. So as I told you, I have 3 different technologies of focus shockwaves at my clinic, and we swear to one of them because that's what suits us the best, but every clinician is different and has probably different patient repertoire in the clinic. So try out the different technologies and see what fits you the best.
Great. So a question again from Emma Deakin. She's asking, have you got any experience with using it on Paralympic athletes, specifically with muscle tone? And have you had any positive or negative effects? Have you got any experience?
I've been working with a hospital with their physiotherapy department, and they use the focus shockwaves on spasticity. And they have very good results on using them, because a lot of the Paralympic athletes, they have a lot of tendinopathies and strain and overload of their working limbs. And if they also have some form of spasticity, it works very, very fine. And they administer the focus shockwave at the muscular tendinous junctions. And it creates a lot of better function of the muscles and decreased pain when they actually when they perform their sports. I haven't had the pleasure of treating many Paralympic athletes, so it's not my specialty, but I know it can make a big difference.
Great. I've got another question as well from Matthew Davies. What's your opinion on shockwave treatment for chronic ITB syndrome and inflamed bursa on MRI? If there is high irritability, is there a risk of aggravation of symptoms?
No. As I told you before, it does not create, even if you have an acute bursitis, it will not exacerbate or increase the bursitis by actually applying focus shockwave. increase the turnover and regeneration of the tissues. And the hip is like quite complex, like iliotibial band syndrome, frictional syndrome, causing some underlying bursitis. I see very rarely bursitis in elite athletes. I see more like iliotibial band friction syndrome and tendinopathies around the greater trochanter. And most of them respond very well to focus shockwaves. And you have to treat the whole lower limb, lateral, anterior, and posterior aspect when you treat these patients. But I don't think you should be worried about bursitis. If I have a large bursitis, I always aspirate and inject the steroid. And I wait 2 weeks, and then you can start out with treating conservatively and utilize focus shockwaves. So you have to find out what's most pertinent. So if you have a lot of loss of function and you have a large bursitis, I would always recommend injection of therapy to start out with to accelerate the healing, and then after 2 weeks go on to focus shockwave therapy, if that's indicated.
Brilliant. I hope that answers your question, Matthew. We've got another question from Duncan. What's your experience of the response pattern versus ongoing treatment? So how long would you tend to persist with different pathologies with little response before you end up moving on to reassess or even use different treatment options?
Yeah, because I treat many athletes, I treat quite aggressively. So we treat twice a week for 3 weeks. And then we reevaluate for pain modulation and the functional levels. And we try to start them up as fast as possible with some form of loading. And I'm most often successful actually going into a more detailed exercise regime after the 3 to 4 weeks with larger injuries. But I always follow my patients and ultrasound scan them from week to week so I can see what's going on. And I nearly always stress the tissues every week to see if they respond, but I wouldn't be, depending on what lesion it is, you have to take into consideration how fast they heal up, but they should respond within 2 to 3 weeks. You should have some kind of response. Sometimes with very chronic lesions, you just know it's going to take longer time. So you have to take that into consideration too. So it's not an easy question to answer. But I wouldn't give them 10 treatments for 2 months without any kind of relief.
I suppose it just comes down to patient selection and just, you know, assessing and selecting them, making sure that the right candidate for the treatment.
Exactly. So do your proper work in comprehensive examination, and always do some radiological work if you're in doubt. I would definitely refer to that if you're not sure what's going on before you actually start a treatment plan.
Cool. There's another question as well, is what is the penetration depth for the hip? So what kind of depths are you looking at? I mean, I suppose around that bursitis area and maybe deeper.
Most very large muscular lesions don't lie further down than 5, 6, 7 centimeters, and we're able to reach that with no problem. Very obese people, but that's not the athlete. So it's quite easy to get to. We have most problems with strength powerlifters and weightlifters, which are very muscular. But you can always, by utilizing the different equipment, you can also manage them and place them anatomically so you can actually get into the tissues. So most of the devices can actually go into 8 to 9 centimeters, and that's plenty of penetration to play with.
Brilliant. Another question that's come in, a slightly more technical question, is for somebody who's looking at a shockwave system, how important is it to look at durability and the energy levels, and also just like the running costs? Like, what's your experience with that?
Of course, as a clinician in a setting where you have full workload and you're busy all day long, you have to, in my experience, I've chosen equipment that is most easy to operate, that starts up very quickly, and where you don't have to do much maintenance, because that's gonna cause a lot of time waste when you actually have a full calendar of patients all day long. So the newer technologies, they are much easier to work with than the older ones, and they are not they're much more cost effective due to minimal maintenance repair. You also have to look at the power output and the distribution of these focused shockwave zones, because every manufacturer has written down some details, but they don't always apply in clinical practice. So you have to be able to actually work with different equipment. So I have 3 devices which say they can actually deliver energy, but in practice we don't see that. So some devices produce a much more homogeneous and dense focal zone, and that's what, in our experience, produces the best results.
Great. And I think one of the last questions, I mean, from my perspective, is that when you look at the research, it's very, very difficult to compare even just looking at patellar tendinopathy, because the study designs are so different and the energy levels that they use are so different. I mean, from your experience, do you see any correlation between using a particular energy level to stimulate a particular response? So if you're looking at neovascularization, for example, is there a particular energy level that you sit within?
Actually, we know most of literature and my shows and my personal experience shows that low to moderate doses are plenty in actually treating most musculoskeletal injuries. And even all the manufacturers actually produce equipment now that you also can treat bony lesions with, and cartilage lesions where you have to go a little bit further up in dosage. But what we thought in the old days, where you had to use very high doses, does not seem to apply anymore when we use it in clinical practice and look at the research which has been done. So I stay within low to moderate doses, and I just choose some equipment which actually produces where I can actually adjust the equipment to deliver as much energy at the fastest time as possible to stretch and shock the tissues to start regeneration and to pain modulate them.
Perfect. And from your experience with athletes, talk about the depths again. Just had another question pop in. Is what would you recommend, so if you're looking at systems, what depths would you be looking at getting?
I'd say I think most systems can actually penetrate from skin level up till 8 or 9 centimeters. But I would definitely, even though you have to consider one thing, that the further down you go into the tissues, some of the energy is going to dissipate by refraction and dissipation and so forth. So you have to increase the power outlet on the machine so it actually responds to the real dose in the deeper tissues. The more muscular the patient is, the more bony anatomical landmarks which are nearby, especially when you talk around the spine and pelvis, the more energy is going to dissipate. And clearly that's where we see that the machines with a higher pressure output can actually have a greater effect there.
Perfect. Well, I think that's everything. I mean, if anybody's got any more questions, then they can send them through afterwards. But otherwise, Anders, I'd like to thank you very, very much for your time. Thank everybody for their participation as well. If you do have any more questions about the application of Shockwave, particularly around bone, tendinopathy, and you want to know a little bit more, then please feel free to reach out to us at PhysiQuip. Otherwise, thank you very much. And I hope you all have a wonderful evening. Thanks, Anders.
Bye-bye. Take care.
Bye-bye.